Welcome to the Cricothyroidotomy course. This course was developed by the VCU Center for Trauma and Critical Care Education. My name is Dr. Alan Rossi. I am an assistant professor of surgery in the VCU Division of Acute Care Surgical Services and the medical director of the VCU Center for Trauma and Critical Care Education and the VCU Paramedic Program. Today we are going to discuss the procedure for an emergency surgical airway. In an emergency situation, the A in ABC is airway. One of the most important questions that you need to ask yourself in an emergency is, does this patient need to be intubated? I like to keep things simple. There are a lot of reasons to intubate someone, but we can think about 4 questions that summarize a lot of those examples of why you may need to be intubated. The 4 questions that you should ask yourself are as follows. Is the patient able to oxygenate? Is the patient able to ventilate? Is the patient able to maintain an airway? Will the underlying injury and physiology of the patient lead to a failure to maintain the airway, a failure to oxygenate, or a failure to ventilate? These key questions summarize a large volume of situations of why you may need to intubate someone. And these are the 4 questions that you can think about. Can they get oxygen? Can they ventilate? Can they move CO2? Can they maintain their airway? Is their GCS decreased to the point where they cannot maintain an airway? Or is there something that may happen over the next few minutes or hours that may lead to a problem of one of these other 3 questions about oxygenation, ventilation, or maintaining an airway? These 4 questions form the foundation of why someone may need an emergency intubation. The focus of this presentation is on the surgical airway. Why would somebody need a surgical airway? We discussed on the previous slide why someone may need to be intubated. The reason that someone may need a surgical airway is if the intubation has failed. Another reason that someone may need a surgical airway is if they have extensive craniofacial trauma and there is no oral or nasal route possible for the intubation. So once again, keep things simple. Why would you perform a cricothyroidotomy? The first reason is if the intubation fails. The second reason is if there is not a route for the intubation to be performed through. Those are the indications for a cricothyroidotomy. The greatest impediment to a cricothyroidotomy is failure to recognize that it is necessary. The cricothyroidotomy is performed through the cricothyroid membrane. The cricothyroid membrane is located between the thyroid cartilage and the cricoid cartilage. When you palpate the neck, you can feel the thyroid cartilage and the cricoid cartilage. These 2 cartilages create a scaffolding to hold up the cricothyroid membrane and make this a very anterior site for the surgical airway. The scaffolding of these cartilages creates a foundation to allow you to palpate these anatomic sites, and it also allows the area not to collapse. If you palpated emergently over the trachea, that site would collapse and compress because the anatomy of the rings does not allow the structure of the trachea to withstand your palpation. That is why the trachea would not be a good site. As you palpate and push on the trachea, you collapse the airway. The trachea is also much more posterior than the cricothyroid membrane. So the anatomy of this area can be palpated, but it also has a structure to it. It keeps it up and anterior while you are palpating. It does not collapse and compress. The best way to find the anatomy on palpation is to start at the sternal notch. Start at the bottom and work up. Palpate the sternal notch, and then as you work up, you will feel the trachea. Slide your finger up the trachea until you feel the first bump. The first bump is the cricoid cartilage. Then you will feel a divot. Then there is a second bump. The second bump is the thyroid cartilage. So once again, start at the sternal notch, feel up the trachea, then you will have a bump, then a divot, then a bump. The two bumps represent the cricoid cartilage and the thyroid cartilage. The divot in between is the cricothyroid membrane. The divot that you palpate is where your surgical airway is performed. This slide shows another reason why the trachea is not a good site for an emergency surgical airway. Not only is the trachea compressible and collapsible, not only is the trachea more posterior when compared to the cricothyroid membrane, but the trachea in the neck is also posterior to the thyroid gland. So with the thyroid gland in the way, and with the trachea being collapsible, and with the trachea being more posterior than the cricothyroid membrane, these are some of the reasons why the trachea is not the site recommended for an emergency surgical airway. The next set of slides will show sequential pictures of anatomy working from the external landmarks down to the larynx. Here are the external landmarks of the neck that can be palpated. Again, I recommend starting at the sternal notch and then sliding your finger up along the trachea. Then you will hit the first bump, which is the cricoid cartilage. Then there is a divot, which is the cricothyroid membrane. Then the second bump is the thyroid cartilage. Again, start at the sternal notch and slide your finger up along the trachea until you hit the first bump, which is the cricoid cartilage. Then there is a divot, which is the cricothyroid membrane, and then the second bump, which is the thyroid cartilage. The divot between the two bumps is the area for the surgical airway. You will make a vertical incision in the skin over this area. This is the area of the cricothyroid membrane. Vertical incision through the skin, which will then bring you through the layers, and this includes staying in the midline, which the next layer down is the platysma, making sequential vertical incisions in the midline through this layer, through the center of the strap muscles. All of these incisions should be vertical incisions. The reason that we do vertical incisions through the layers is because the major blood vessels in the neck run vertically. You want to keep your incisions in the midline vertical through the layers until you reach the larynx. Along the way, you should be palpating to keep yourself in the midline. So you can make a cut and then remove the knife and stick your finger in, and then take your finger out and put the knife in and go back and forth until you've cut all the way down and can palpate the larynx. You do not want to have the knife and your finger in the incision at the same time. This is dangerous, and you want to avoid situations where you may injure yourself. Once you get down to the layer of the larynx, where you have the palpable thyroid cartilage and the palpable cricoid cartilage and the cricothyroid membrane in between, at this point, you are now going to make a horizontal incision through the cricothyroid membrane. Looking at this picture explains why we do a horizontal incision. The cricothyroid membrane is longer in width than it is in length. So you can make a longer incision from side to side than you can from top to bottom. This needs to be a controlled stabbing incision to get through the membrane. You do not want to stab all the way through the posterior side of the airway, but you want to have a controlled entry through the cricothyroid membrane in a controlled stabbing motion and then create that incision across the membrane. It is important to learn how to perform emergency procedures with minimal equipment. You do not want to learn how to perform a cricothyroidotomy with a kit, because in an emergency situation, if a kit is not available, you want to be able to perform the procedure. So the necessary instruments include a scalpel and a small endotracheal tube. The recommended size would be a 6/0 tube or smaller. With the scalpel and with the small endotracheal tube, you can perform a cricothyroidotomy. You do not need any other instruments. If you have the ability to have additional instruments, then a small clamp would be helpful, such as a hemostat. Suction would be helpful, and a bougie may also be helpful. And we will talk about all of these instruments. But once again, the necessary instruments include a scalpel and a small endotracheal tube. The cricothyroidotomy procedure should be performed quickly. This is a life-saving procedure in a patient who is dying from an airway issue. These steps show how to perform the procedure for a right-handed person. If you are a right-handed person, you will stand on the right side of the patient. You will use your left hand to stabilize the larynx and the trachea, and you will use your right hand to identify the surface anatomy and to perform the procedure. If you are a left-handed surgeon, then you will perform this procedure on the left side of the patient and reverse the hands that are described here. Again, for a right-handed surgeon, stand on the right side of the patient. Use your left hand to stabilize the airway, holding on to the larynx and the trachea. Use your right hand to be feeling the anatomy and also performing the procedure. Vertical skin incisions over the cricothyroid membrane. Again, identifying the membrane by starting at the sternum, sliding your right hand up the trachea, feel the cricocartilage, the divot, then the thyroid cartilage. The divot in between is your emergency airway. You have been feeling this with your right hand while stabilizing everything with your left hand. Now you've identified your site and you're going to make a vertical incision over the cricothyroid membrane. This is an emergency procedure, so you want to make your incision large enough to be able to perform the procedure successfully. And you will continue to divide the layers down to the level of the airway. Once you get down to the airway, because you were making cuts and feeling and checking your anatomy as you go down and constantly palpating, making your cut with the right hand, removing the knife, using your left hand to feel in the hole and then going back in with the knife, back and forth, never having the knife in your finger in the hole at the same time. But once you get down to the airway and you palpate that airway, that divot in between the two cartilage structures, once you get down to that, you are going to turn your knife and you're going to make a horizontal incision through the cricothyroid membrane. This again is a controlled stabbing incision, and you make the stabbing incision and work horizontally across the membrane. You should see and hear air blowing out of the open airway. Once you get into the airway, you need to dilate the incision. At this point, you can use your finger to dilate the incision, or you can use a small clamp such as a hemostat if available. Do not use the scalpel handle. If you use the scalpel handle, that means you have to turn the scalpel around and the blade will be pointed at you and your hand, and you will be at risk of injuring yourself. Do not use the scalpel handle to dilate the cricothyroid membrane. Either use your finger or a small clamp. Once you have dilated the incision through the cricothyroid membrane, then you will place an endotracheal tube through the cricothyroid membrane into the airway. The option at this point is that you could also place a bougie, meaning that once you have opened and dilated the cricothyroid membrane, you can place a bougie into the airway first, and then once the bougie is in the airway, then you can slide the endotracheal tube over the bougie into the airway. You do not need the bougie, but it is an option at this point, and if you have it available and feel comfortable with it, you can use a bougie before placing the endotracheal tube. Once the endotracheal tube is in the airway, inflate the cuff and attach the endotracheal tube to a BVM or to a ventilator in order to ventilate the patient. Important concepts. This procedure is a blind procedure. You need to feel your anatomy throughout the procedure. There will be bleeding. Remember, A is the first letter in ABC. You need to secure the airway. You need to work through the bleeding. Remember, we are making vertical incisions through all the layers. The major blood vessels run vertically. Your goal is to stay in the midline and stay between them. There may be small branches that may get cut during the emergency procedure, but you work through the bleeding. You can control the bleeding after the airway has been controlled. When you open the cricothyroid membrane, insert the endotracheal tube until the cuff is just inside the airway. It is very easy to right main stem the patient with the endotracheal tube. Remember, the endotracheal tube was made for placement through the mouth. So the numbers on the endotracheal tube are where we usually measure at the teeth or at the lip. Those measurements at the neck would place the endotracheal tube too far into the patient. So the recommendation is that when the cuff is just in the airway, stop and inflate the cuff at that point. At this point, hold on to the endotracheal tube, even if it is secured. It is very easy for the endotracheal tube to move. You have just secured the airway in an emergency. You want to hold on to that airway until a more definitive procedure can be performed, such as a tracheostomy in the operating room. So even if you secure the endotracheal tube with suture or with tape, I still recommend holding on to the endotracheal tube. At this point, there will be multiple video presentations for surgical airway access. The first video is a step-by-step open cricothyroidotomy. The second video is a real-time open cricothyroidotomy. The third video is a step-by-step needle cricothyroidotomy, and the fourth video is a real-time needle cricothyroidotomy. At this time, we are going to demonstrate a surgical cricothyroidotomy in an adult patient. This is a two-handed procedure. If you are a right-handed surgeon, you should stand on the right side of the patient. If you are a left-handed surgeon, you should stand on the left side of the patient. I am going to demonstrate a surgical cricothyroidotomy for a right-handed surgeon. So as we stand to the right side of the patient, I'm going to use my left hand to stabilize the airway and also help me to identify anatomy. So as a review, when we're feeling the anatomy on the neck, it's easy to start at the bottom and feel the sternal notch. Then when you go up from the sternal notch, you're going to feel a soft structure, which is the trachea. Then you're going to feel your first hard structure, which is the cricoid cartilage. Then there's a divot. Then there's the thyroid cartilage. So between the cricoid cartilage and the thyroid cartilage is the cricothyroid membrane. And that is your surgical airway site. It has a nice scaffolding of the two cartilages above and below. So once again, easiest to feel from the bottom and quickly feel up, hit something hard, then a divot, hit something hard, and you are working between the two hard structures. So I'm going to use my left hand to stabilize that airway. Now as a review, we're going to open the skin here and look at the model. And what you can see is what we've demonstrated. We're working down here at the sternal notch. Here's the trachea. This is the first hard thing, which is our cricoid cartilage, then the divot over the cricothyroid membrane, and then the next hard thing, which is the thyroid cartilage. So as we work our way up, our finger hits something hard, a divot, hard, and we're going to stabilize that with our left hand, since I am a right-handed surgeon, and then I'm going to work over the cricothyroid membrane. When we're using our knife to do the procedure, we're going to cut away from ourselves so we don't hurt ourselves. You can use an 11 blade, you can use a 15 blade. You can use any blade that you need. This is an emergency procedure. You should cut away from yourself. You do not want to cut toward yourself and slide into your hand. So the first cut is going to be over the cricothyroid membrane that we have identified. And we make a large cut. This is not a time for a small cut. This is a life-saving procedure. So you're going to cut through the skin and you're going to continue to cut down until you can feel that you've cut all the way down. So it's a motion of going back and forth. Cut, stick your finger and feel, cut, feel, cut, until you feel that you're at the cricothyroid membrane. Then you're going to turn your knife and you're going to cut horizontally into the cricothyroid membrane. And this is almost a controlled stabbing technique. You need to puncture the membrane, and then you're going to cut across horizontally. You will know that you are in because you will see air release, and you'll hear air release, and the way that you usually see it is, because it is bloody, you'll usually see air pass by some blood that comes up. So that's a quick internal demonstration of a large sequential cuts, feeling back and forth. I would not recommend sticking your finger in the knife at the same time in the hole. That is dangerous to you as the surgeon. Once you feel that you're all the way down, you turn the knife and you're going to cut horizontally. So here we're going to close the skin. I'm going to approach the patient and I'm going to feel my anatomy. I'm stabilizing with my left hand. I feel the sternal notch. I slide up. Hard thing, gap, hard thing. This is my area. I stabilize with my left hand. I grab my knife in my right hand. I'm going to cut away from myself with a large cut over the cricothyroid membrane. And I could feel, and I stick the knife in, and I'm cutting, and we're doing this with minimal instruments. You don't want to have to learn how to do this with a kit. You want to be able to do this with anything. So I'm continuing to cut through the layers, staying in the midline, until I feel the cricothyroid membrane. Then I'm going to stick my knife inside, and I'm going to turn it horizontally, and I'm going to puncture the cricothyroid membrane, and I'm going to cut across. At this point, I can stick my finger in and feel my finger is in the airway. I can dilate with my finger, or I can dilate with a clamp and stick that in and dilate. What you do not want to do is dilate with the back of your knife handle. If you turn your knife handle around and dilate with the knife handle, you are at risk of cutting yourself. Please do not do that. So you can either dilate with a finger, with your pinky finger, with any finger you have, or if you have a clamp available, you can stick a clamp in and dilate. And I can feel the airway is open, and at this point, I can insert my ET tube, which should be a 6 millimeter ET tube or less. And what we're going to do is we're going to feel our anatomy, and we're going to guide the ET tube into the hole. And once the cuff is just inside, we stop, because we do not want to right mainstem the patient. Then we can use our syringe to inflate the cuff, and then we maintain our grip on this in order to secure this in whatever way we want to. But I would recommend, even if you secure the ET tube, I would still hold on to it. Then you can attach this ET tube to a BVM or to a ventilator, and you have now gotten your emergency airway. As another option, you can also use a bougie catheter. So I'm going to deflate this and just show you another optional technique here. I'm going to take this ET tube out. So at this point, I have already punctured the cricothyroid membrane. I feel that it's open. I use a bougie catheter to slide in, and I slide it, and I can feel it going along the trachea. Then I'm going to take my ET tube, and I'm going to slide it over the bougie catheter and slide it into the airway. Once the cuff is in, I can remove the bougie, just like before, and I can inflate the cuff, and then we can attach our ET tube to a BVM or to a ventilator in order to oxygenate and ventilate the patient, and I'm going to hold this in place. This is our surgical airway. The last demonstration I want to show is just what it looks like without the skin on it. So I'm going to take this tube out. We're going to open the skin again. I've already made my cuts. You can see that the cut has been through every layer. So we're staying in the midline, so the skin, and then all of the layers in the midline of the neck until we get down to the airway. You can see my horizontal incision in the cricothyroid membrane, and I'm able to stick my finger inside to dilate, or I could stick a clamp inside to dilate. Once I've dilated and verified my anatomy, the ET tube goes into the opening, and once the cuff is just inside, we inflate the cuff, and we attach our ET tube to a BVM or to a ventilator. And at this point, we've secured our airway. We hold the airway in place. We secure it with different techniques, but once again, recommending always to hold it with your hand. And then we move on to the next steps, which is going to be getting a more definitive airway, which could possibly include doing a formal tracheostomy in the operating room. In this example, we are only going to use a knife and an endotracheal tube. Minimal equipment that you need for a surgical cricothyroidotomy. Again, this is a 6.0 tube. I would recommend a 6.0 or smaller. And then you can use any knife. Here we're going to demonstrate it with an 11 blade. And remember, you want to cut away from yourself. For the dilatation, because this is the only equipment that I have, I'm going to use my finger. So a knife, an endotracheal tube, and using my finger for the dilatation. And that will allow us to do this procedure with minimal equipment. Again, I am a right-handed surgeon, so I'm going to approach the patient from the right side. This is a surgical emergency, so I'm going to use my two hands. Left hand is going to feel my anatomy and stabilize, sternal notch, bump, bump, space in the middle. I get my knife, and I'm going to cut vertically, feel, cut, feel, cut, I feel my cricothyroid membrane. I get the knife in, turn it horizontally. I get through the cricothyroid membrane. I use my finger to dilate, and I'm going to insert the endotracheal tube until the cuff is just in. I'm going to inflate the cuff. I'm going to hold on and attach it to a ventilator or to a BVM. At this time, we're going to demonstrate a needle cricothyroidotomy. A needle cric is performed on children. The indication is for children 12 and under. In this age group, you would not be doing an open surgical cricothyroidotomy. The recommendation would be to do a needle cricothyroidotomy. Once again, we want to learn this skill with equipment that can be found almost anywhere, and minimal equipment. We don't want to learn this skill just with a kit that might not be available. The other thing that comes up is the need for a jet ventilator, which people might not have available or might not know where that is in an emergency. So we're going to learn how to do an emergency needle cric with minimal equipment so that we can attach it to a BVM. So there are different options for the needles. This is an example of a 14 gauge IV that has an angiocath. And when you open it, you can see the angiocath on the needle, and it has this little adapter on the end, which you would want to remove so that you can attach a syringe to the end of this needle. And then you'll be able to pull back on the syringe and get back air to see that you're in the airway, and then be able to slide in with the angiocath. If you have a 14 gauge IV with an angiocath, this would be ideal. The other angiocaths that people might see are these IVs that are protective. On this, there is a needle and an angiocath, but it has this protective component. And this would be where if you were getting IV access, you would slide this forward. But what you can notice is there's nowhere to put a syringe on this. So if this is all that you have, you can use this, but know that you can't attach a syringe, so you won't get the feedback of seeing air enter the syringe. But in an emergency, you can use the protective IV without a syringe if needed. Now once you have the angiocath in the airway, what do? Because you can't attach this to anything, and as we said, we want to learn how to do this without a jet ventilator. So we're going to have this inside the airway, and basically we can take a syringe. Here we have a 10 cc syringe, but you could use a 5, a 10, or a 20. And if you pull out the plunger and attach the syringe to the angiocath, then you can take your endotracheal tube and put it in to the syringe, and then you can inflate the cuff, and then you have your endotracheal tube in the syringe, and then you have your angiocath, and then you can attach this to a BVM so that you can at least start with getting some oxygenation in this emergency in the needle cric. So let's now demonstrate this procedure with all the steps. Once again, this is for a child under the age of 12. So we're going to have our angiocath ready with our needle, and here we're going to demonstrate the angiocath where we can attach a syringe to the back of it. I'm going to set up our syringe again, and remember it can be a 5, a 10, or a 20. We have our syringe here, and on this situation I am a right-handed surgeon, but because I'm doing a needle cric, I want to stand on the left side of the patient. I'm going to feel my anatomy, and I can feel again the sternal notch, the trachea, the cricoid cartilage, the divot of the cricothyroid membrane, and the thyroid cartilage. So I'm going to use my left hand to stabilize and feel my anatomy throughout. Then I've got my angiocath, which I'm going to insert at a 45-degree angle into the skin. And in a real patient, if you start drawing back here, there will be nothing in the syringe because you are in the tissues between the skin and the airway. But you'll draw back in a similar fashion to placing a central line, and you will go forward until you enter the airway and see air fill the syringe. Now I'm in the airway with the needle. So I'm going to slide the angiocath forward into the airway and remove the needle. Then I could take the needle off, take the plunger out, and attach my syringe to the angiocath. Then I got my ET tube ready, and I'm going to insert my ET tube into the syringe, inflate the cuff, and then I have my angiocath, my syringe, my ET tube with the cuff inflated, and then I can attach the ET tube to a BVM in order to start to oxygenate the patient. At this time, we are going to demonstrate the needle cricothyroidotomy in a patient age 12 or under in real time. Again, I am a right-handed surgeon, so I will approach the patient for a needle cricothyroidotomy from the left side so that I can use my left hand to stabilize the airway and use my right hand for the procedure. I approach the patient, I use my left hand to feel the anatomy, sternal notch, trachea, cricoid cartilage, divot, thyroid cartilage, stabilize the airway. I use my right hand and insert the needle at a 45-degree angle and insert it until I get air back. Slide the angiocath forward. Take the plunger out of the syringe. Attach the syringe to the angiocath. ET tube into the syringe. Inflate the cuff. And then I can attach my endotracheal tube to a BVM.
This completes the cricothyroidotomy course. All of the videos involved in this presentation are available on the website to be viewed outside of the presentation. There is also a reference card available on the website that summarizes the steps of the cricothyroidotomy procedure. On behalf of the VCU Center for Trauma and Critical Care Education, thank you for completing the course on cricothyroidotomy.